Dear pure urologists, good evening one and all. Sorry for the delay because of the technical issues. Today we are discussing about supine PCNL made easy for beginners step by step by Professor Sandeep Gupta. I will briefly introduce because we are already running short of the time. I will introduce about so this is the program today. Supine PCNL easy for beginners step by step. And Professor Sandeep is past MCH from RIMS, Impal, Manipur in 2014. They did a fellowship in 3D. He did fellowship in 3D laparoscopic urology under George P. Abraham sir in 2015. Presently working as Professor Department of Urology, WBMES. He is also senior visiting consultant in various corporate hospitals in Kolkata, ILS group of hospitals, Manipal, Amri group of hospitals. Appointed by Government of West Bengal as renal transplant inspector since 2018, inspected many hospitals and given the permission. One of the first to start and regularly perform published papers on supine PCNL in Eastern India. Field of interest, again, supine PCNL laparoscopy. I'm happy that many are doing supine PCNL. Thank you, Sudeep and Sandeep. And I thank for coming to this program. I hope the audience will get benefited because of your step-by-step approach. Over to you, please.
Thank you, sir. Good evening, everyone. Thank you so much, sir, for giving me this opportunity. I'll just start now, sir, because we are already running out of time. So we'll just discuss the basics of supine PCNL, sir. And as we all know, it's just like any normal PCNL. And the most important thing in supine PCNL is the puncture. So patient positioning, puncture, case selection, these are the things which I'll be highlighting today. And I'll be sharing 2 videos on how to puncture and how the CM moves along with the puncture. So the main problem is that we don't want to accept change. We are always being told that PCNL is to be done in prone position. But nowadays things have changed, and supine, I believe, is the way forward in PCNL. When I started supine PCNL in 2016, I was also told why you are doing it in this way. But the first case I did was more of a compulsion because the anesthetist refused to give the anesthesia in prone position. So someone suggested to me, why don't you try supine? So I was also very reluctant, but I had no other option. And luckily for me, the case went well. So from then on, I started picking up supine PCNL and I gradually improvised it. So these are the various positions in which PCNL has been tried. But yes, we all know that prone is the mostly followed way.
Your screen is not shared.
Sir, it's shared, sir?
No.
1 minute, sir. Share screen.
Yeah, share screen.
Sir, yeah, now, sir?
Now it is shared. Now your position is seen.
Okay, sir.
Go to the first slide if you want.
No, sir. That's okay, sir. Now, am I visible, sir? The slide? Is the slide visible, sir?
And you can make it bigger by clicking the link at the bottom.
Okay. Yeah, it's full screen now, sir, in my laptop.
Okay, it's all right. It is visible clearly.
Okay, thank you, sir. So all the positions, these are the various positions that have been tried. What are the advantages of supine? Number 1, optimal cardiovascular and airway control. So we'll see that the anesthetists are the happiest people when we tell them that we are going to do the PCNL in supine position. It's very good in high-risk patients with heart failure, morbidly obese patients, and it can be done in spinal anesthesia also with ease. If needed to convert to GA, it can always be converted without changing the patient's position again. No patient repositioning is needed. The only position is lithotomy, and then after the UCAT is put, you just modify the position a bit and you are ready for the position for the PCNL. In high-risk cases, as I've told, it's very good. Better stone washout rate due to horizontal dorsal sheath angle, less chance of colonic injury. Various studies have shown that the chance of colonic injury is less in supine as compared to prone. Initially, we used to think, even I was worried that there will be more chance of colonic injury in supine as compared to prone. But studies have shown, including the publication that I have made, that colonic injury is more in prone as compared to supine. There's always a combined opportunity of ECIRS in supine PCNL. Less overall X-ray exposure is also done with a high stone-free rate. So from anesthesis point of view, these are the advantages of supine PCNL. I've already mentioned that. Better drainage, I've told already. The only thing is that the intrarenal pressure is
you
very
move the slide.
less.
Is it moving? Slide is moving.
Yes, sir. Yes, sir.
My slide is fixed here 3.
No, sir. I've already come to 6, sir.
No, it is 3 only.
I'll again do, sir. Now, sir.
No. Yeah, now it is moving. So that
Okay.
means every time you have to move with your cursor.
Okay, sir. I'll do that, sir.
Please. So go to.
I'll again go to screen share, sir.
Go to 4th slide.
4th. Okay, sir.
Yeah, this is optimal cardiovascular. Better high risk patients can be done in spinal. No patient repositioning needed. Next. It is not going down like that. You have to click on the fifth one.
Okay, sir. Now, okay, sir.
Yeah, next 6th one.
Sir.
Next 7th one. Yeah, now we are here. So,
sir, should I make it full screen or not, sir?
Yeah, full screen. It is not made full screen here.
Now I am full screen, sir. Can you see my full screen, sir?
No. You go to the slideshow above. Can you see the slideshow above? Top slideshow. Animation, slideshow, design.
I'll escape. Yes, sir.
No.
Slideshow.
Slideshow top is there. Top on the top slideshow is there.
No, sir. My slideshow is in the here, sir. Slideshow, and I've clicked it.
Yeah. Click it, and now you it is not enlarging. So no problem. You click with your cursor only.
Okay, sir.
No other option.
Okay. Now, okay, sir.
Yeah. Okay. Better drainage is a slide now.
Now, no, sir. I've come to ergonomics.
No, you have to click 9. You have to click with your cursor. Slideshow is not there.
Okay, sir.
Yeah. You have to click like that, please.
Okay, sir. So it's better for the surgeons also. We can always sit down and do the PCNL. And the less exposure of the surgeon to the C-arm is also there, because it favors supine position owing to the direction of axis. There's no conflict between the instrument and the C-arm. So the annoying movement of the C-arm in and out of the operative field is never needed during the procedure. Yes. Radiation hazard also, I've told, is less as compared to prone position. Less chance of colonic injury, that also I have already discussed. ECIRS we can do. Various studies have shown that supine is better than prone. Obviously, there are some disadvantages also in supine position. There's limited space for renal puncture and scope mobility. Upper pole calyx are more medial and challenging to do. More complex dilatation due to high kidney mobility. Increased risk of spleen and liver injuries. There's decreased filling of the collecting system. It's always in a collapsed state because the water is always draining out. Spinal interposition is a major problem which I have faced. Sometimes we are not able to see the stone also, and we may have to change the C-arm angle. And longer length trap is also one problem in this case. So how do we select the patient? So ideally, as in beginners, I'll tell always select clean and simple cases. Go for lower calyceal, middle calyceal, or pelvic stones with hydronephrosis, because in the initial period you would want the confidence level to be built up. So there should not be any failure of cases. Don't select complex cases. Don't select stag-on cases. Clean-cut cases, initial few cases, you will be successful. It will increase your confidence. Then slowly, steadily, you can go for stag-on and upper calyceal stones. Bowel preparation, very good. Bowel preparation is needed in supine PCNL. Low residue diet, 2 days before OT I give. Liquid diet only the day before OT. And P enema also I sometimes prefer. Anesthesia, GA is preferred because during puncture and dilatation, I personally feel the kidney should be constant and it should not be moving. So which becomes difficult in spinal anesthesia because the patient may not cooperate. However, I've done some cases in spinal and they have also been okay. But I still prefer GA. the basic instruments, whatever we need in a PCNL. These are the things we need. So supine positions have been tried since 1987. So the most accepted one is the Galdeco modified supine Valdivia position. That is the most commonly practiced position, and I also do my supine PCNLs in these positions also. There are other positions like Bart's flank free approach and also the Fala-Hutkar approach. These are the various positions of the supine. Completely supine is also there. Split leg position has been tried by many people, but the well accepted position is the GMSV position. This is the GMSV position. I'll show in the another view also, where the ipsilateral side we have the leg straight, and the contralateral side the legs are flexed. The hip is flexed rather, so that there is space for us to enter. Now one thing is that in GMSV, the flank is always supported by a sandbag or some cloth. But initially I used to do in this position, but then space constraint used to be there, because once we put the sandbag or something below the this place, then the limited space is available. So nowadays what I do is I keep the flank free. So I don't put any bolster or sandbag in the posterior aspect, and that gives me some more space, especially in obese patients. So these are the side view and the front view of the patient position. Now the markings. I prefer doing the markings in the once the patient is anesthetized and the patient is positioned. And the most important three landmarks that we need to know are the posterior axillary line, the costal margin, and the iliac crest. Of these three, the most important is the posterior axillary line. And always remember one thing: be always posterior to the posterior axillary line. Never go anterior to the posterior axillary line, and be as posterior as possible. Suppose we start the puncture from this point, we are not able to access, then you can always go anterior. So initially try to go as posterior as possible, then slowly, gradually you may attempt a bit more anteriorly, but never cross the posterior axillary line. These are the main important things we should remember when we are doing supine PCNL. So again, the landmark markings after patient positioning. So now the most important thing, the whole game is about the puncture in PCNL, and I have named it gradual ascent technique. It's opposite to our SK Palsar's technique of gradual descent. So just like a flight takeoff from the runway, the puncture should be in that direction. So the C-arm, I always tilt 20 degrees towards me. That is the position of the C-arm during the puncture. And it's just like a flight takeoff from the runway. So this is the way, if I may show with images. So the angle of ascent, this is called the angle of ascent. This red angle is the angle of ascent. This is the direction of the IP needle. This is the kidney. We have the desired calyx and the stone on it. This is the anterior aspect of the patient. This is the posterior aspect. So this angle of ascent we have to remember. So I'll show a small video in the end, but please see in this slide. This is the most important slide of the presentation. So once we puncture with the C-arm tilted 20 degrees towards us, and suppose we see that the stone and the desired calyx are in the same position, then we tilt the C-arm away from us to 0 degree position. If we see that once coming to 0 degree, both the stone and the C-arm, both the stone and the calyx, I mean the IP needle and the stone are again coinciding in the same way, then we are in the system. But please look at the second image. Once we puncture in 20 degree and we rotate the C-arm to 0 degree, if we see that the IP needle has moved medial with respect to the stone, then that means we are posterior. In this case, we are more deep. So hence, you withdraw your IP needle and then you again go in a more superficial plane, that is in a more anterior plane. Similarly, please look at the third image, the third line. Once we are in 20 degree, we feel that we are in the system. Then you rotate the C-arm to 0 degree away from the surgeon. If we see that the IP needle moves lateral, the tip of the needle moves lateral in respect to the stone or the calyx, that means we are superficial. In supine PCNL, superficial means we are more anterior. So you withdraw the needle hub, again go a bit more posterior, that is deep. This is the main thing we need to know in supine PCNL. Once the puncture is done, the guide wire is into the ureter, it's the same like in any PCNL. There's nothing great about it. So this is the main thing in supine PCNL, that is the patient positioning and the puncture. So patient positioning I've already explained. Puncture, please remember this image. This image is the most important image. If we can remember this and follow this principle, I think we should be able to have a nice puncture. A few studies which have shown recently published that supine is superior to prone. Well, some may say that you may do in whatever way possible. Ultimately, the stone has to come out. Yes, that's true. But the comfort of the surgeon and patient is also important. This is my publication in our USI newsletter last year, The Art of Supine PCNL. Whatever images, whatever these things I've shown, it's all there in that newsletter. So you can go through the newsletter and you will be able to understand it. Please read it nicely. I feel we should adopt to the changing times, or else we have to abort. I'll just show a few videos, just 2 videos I'll show. The first one is what I was saying, that
I'm not seeing any video.
Sir, I am okay, sir. Resume share. Sir, 1 minute, sir. I'll close this.
Share the screen and then go to video.
Yes, sir. Yes, sir.
Not visible anything.
Sir, now?
Yeah, you are sharing the screen and video is visible.
Sir.
Yes, please go ahead.
So, sir, with the C-arm tilted 20 degree towards me, I am assuming that I am in the system. I'll show a PIP, sir. Just 1 minute. So if we see here, sir, we are seeing that we are assuming that I am in the system.
Yes.
Okay, sir. Now I'll tilt the C-arm to 0 degree away from me. So as we can see, sir, the IP needle is lateral. So actually I'm where? I'm actually superficial. I'm on my IP needle is actually placed above the patient's body. So I am actually superficial to the stone. So this is the same thing which I've documented and I've shown here, that actually I am superficial. So once I've made the C-arm to 0 degree, my C-arm, my IP needle has shifted laterally. So I am superficial.
Anterior better you tell than superficial.
Sir, anterior. Yes, sir. In this case, anterior. Yes, sir.
If 20-30 degrees in a normal prone PCNL, we shift towards the head, away from the head. You are saying that if the C-arm is rotated away from the head, if the needle goes towards the spine, you are anterior.
No, sir, not away from the head. I am away from me, sir. I am doing.
That's what, away from you, if you rotate.
Yes, sir.
The needle goes towards the spine.
Then I'm deep. Then I'm posterior, sir.
Posterior, right.
Sir. So as we can see, the IP needle is lateral and the stone is medial. Once I've made the C-arm to 0 degree. So I'm C-arm 0 degree, my IP needle is on the patient's abdomen. Now, sir, what I've done is I put the IP needle posterior to the patient's body.
Yeah. If it is posterior to the desired stone,
it will be medial.
kept on the back side of the patient,
Sir,
it appears in 0 degree as if 20 degree as if you are in the.
I'm in the calyx hitting the stone. This is what is appearing.
The camera, you are shifting the C-arm to?
Sir, now again 0 degree. This is 20 degrees, sir.
Okay.
So I'm assuming I'm in the system.
Yeah.
In 20 degree.
Yeah.
But now I'll again shift the C-arm to 0 degree away from me.
Okay.
So I'm now shifting the C-arm away from me. And now we'll see the tip of the IP needle is towards the spine now. It's moving medial, sir.
Yeah. So medial means posterior if the C-arm is shifted away from your head.
Yes, sir. Correct, sir. This is
normally you puncture in 20 degree or 0 degree?
Sir, 20, sir. 20 degree towards me.
Towards you?
Yes, sir.
Like in bullseye in prone PCNL?
Correct, sir.
So your initial puncture is 20 degree towards you.
Yes, sir.
The top part of the C-arm is towards you.
Towards me, correct, sir.
Like bullseye in prone PCNL.
Yes, sir.
After that, you rotate the C-arm to 0 degree.
Yes, sir.
If the needle goes towards the spine, you are more posterior.
Correct, sir.
That's all.
Correct. And if it's lateral, then I'm
puncture at 20 degree, shift to 0 degree. If the needle goes towards the spine, you are more posterior.
Yes, sir.
Puncture in 20 degree, always. You puncture always 20 degree?
Always. I have not done a single supine in 0 degree.
Because it is new for me, I am learning. So I will try in my next cases. Let me give the feedback to you.
Sir.
So you turn the C-arm top part, that is receiver part, towards 20 degree towards you, puncture the calyx. To know whether it is in position or not, you go to 0 degree.
Yes, sir.
If the needle is towards the spine, then you are posterior.
Correct,
then
sir.
you have to slightly withdraw the needle and go more anterior. That is gradual ascent.
Correct, sir. Correct, sir.
Thank you. Thank you.
Sir, one more short video I'll show of 1 minute, sir.
Yes. So now you are 20 degree towards your side.
Correct, sir.
Now you are 20 degree towards your side.
Yes, sir. Yes, sir.
You are below the rib.
I'm below. Yes, sir. This is the 12th
I'm asking
rib.
for the audience, not for
yes, sir. This is the rib, sir. 12th rib. This is the iliac crest.
Yeah, you are below the rib. You are posterior to the posterior axillary line.
Yes, sir. Posterior axillary line, sir.
You are straight going towards the calyx.
A bit slant, sir.
A bit slant. That means you are aiming the calyx tip.
Yes, sir. Yes, sir.
Go ahead. Start the video. Yeah, it is horizontal almost to the ground.
Yes, sir. Right now.
Yeah, you.
Sir, one thing I will say, sometimes it's not a rule that it will always be an ascent.
No
Sometimes
problem.
I may even have to go in a descent.
No problem. No problem. No problem. You selected some point and you wanted to go inside.
Yes, sir. Sir, I am very posterior to the posterior axillary line.
Yeah,
if you can see here, sir.
Yeah,
I've kept a suitable distance away from the posterior axillary line.
That is safe.
Sir.
That is safe as far as colon is concerned.
Yes, sir.
Great. So now you are going.
Yes, sir.
This is blind. You don't know where exact point of origin. With your experience, in between the rib and iliac crest, posterior to the posterior axillary line, you will start at one point. After that, you will decide whether it's not to be done.
And always, sir, the kidney is in a stationary position. I take the help of my anesthetist friend and I tell them that the respiration should be stopped at this.
Yeah, usually respiration should be low. Any PCNL puncture, better respiration should be low so that we'll have idea.
Sir.
This is the advantage of general anesthesia. Whereas in spinal, you have to ask the patient attendant, patient. Okay. Hello?
Yes, sir. Yes, sir. I'm showing.
So you have given a nick?
A nick, sir. With 11 number blade, sir. I go as deep as possible.
Yeah. Why are you doing front and back?
Sir, I want to see whether I'm hitting the kidney or not.
Very good. Kidney movement will be observed by front and back so that how nearer to the kidney you will come to know. Is it correct?
Yes. Yes, sir. Yes.
Thank you.
So in the PIP, we can see, sir.
Yeah, in the PIP, we can see you
Yes.
are reaching towards the calyx.
Yes, sir. Now we can see the kidney has started to move, sir.
Yes, kidney is moving. Jerky movement is there, the way you are moving. Everybody expects this type of movement both in prone and supine, kidney movement, whenever you reach the cortex of the kidney. Now it's appeared to be as if you are in the calyx.
Yes, sir. Appears to.
We don't know. Other angle we have not seen.
So now I'm actually rotating the CM to 0 degrees, sir, with my hand.
It was punctured at 20 degree. Now you are shifting to 0 degree.
Yes, sir. And I've confirmed that in both planes, I'm seeing the same picture.
You are in 0 degree now?
Yes, sir. I'm in 0 actually, but I'm not able to show maybe. But
No,
I've converted from
0.
20 to
You
0.
are in 0, the needle in the same calyx
Same.
position.
Sir. So now I'll take out the hub and I'll see whether water is coming or not.
So water is coming clearly.
Correct, sir. This is the only thing I wanted to show, sir.
Just because in two angles, it is in the direction of the calyx. And so concurrently you have opened and water also has come. That
Correct,
is
sir.
sufficient to proceed with the surgery.
Yes, sir.
Great.
And sir, at the only thing is, while doing the puncture and everything, I always keep palpating the abdomen, whether any distension or anything, because sir, we never know about any colonic injury. So I always, at the end of the surgery also, I always look for any abdominal distension.
With a needle puncture, abdominal distension may not happen.
No, sir, after dilatation.
After this thing, okay. I always feel happy for your point of clinical examination. But what are the other points? There is a question from the Sandeep, same your name. And he says that, is there any clue where you can imagine colon is your close? Indentation of the colon sometimes we observe. Do you accept that?
Yes, sir. So many times while doing the puncture also, we may feel the colonic shadow is also moving.
Yes, then you should avoid and you should go posterior.
Yes, sir. Yes, sir. Definitely we should change the plane, sir.
As simple as it.
Yes.
Yeah, great. So you are way behind the posterior axillary line. You are in between the iliac crest and the rib. You aimed at the calyx, maybe inferior calyx upper part, and you have seen in 20 degree first, and then you moved to 0 degree. Both degrees it was in the center of the calyx. Then water has come. It is straightforward.
Yes, sir. After this, it's just like any PCNL.
Like any other PCNL. Very good. You have any case where you can show anterior and posterior wrong puncture? Do you have video?
Anterior posterior wrong puncture, sir.
Wrong puncture, but first you are posterior, then you came to anterior like that.
Oh, actually, sir, I thought it just.
This is one go puncture. Everybody may not be able to do in one go, even myself. Then in that time, we will move the needle, as you said. If it is going towards the spine, it is posterior. Then you gradually ascend, withdraw the needle and ascend.
Yes, sir.
How much you will withdraw the needle? Completely outside? Better?
Sir, I'll at least come out of the kidney.
Great. So better to completely outside and tilt.
Yes, sir.
Right. Do you have any other video?
Sir, video, next time I didn't, I have many cases, sir. I have had multiple attempts. Videos are there, but it's not yet compiled, sir. If I'll, in the next time, maybe I'll show it, sir.
No problem.
Yes, definitely. Many times it's happened, sir, that I have had to change.
Yeah. For the audience sake, what I personally feel, he has put a lot of effort of explaining this. So with your permission, Sandeep, we will discuss, because I also do supine PCNL.
Yes, sir. Yes.
I will share because time is not over.
Yes,
lot of audience have joined late because we are late.
Sir.
So
I'll exit, sir.
No exit. Why exit?
No, stop share. You will be sharing, sir, some videos.
No. I don't want to share. Generally,
okay,
I don't share when my talk is not there.
Okay,
so what we will discuss, open mind. For example, if you have inferior calyceal stone, let us stop sharing so that we can go one by phase. If you have inferior calyceal stone, middle calycial stone, upper calyx, inferior, middle, upper calyx, and stone is in the pelvis. Usually prone PCNL surgeons will select the inferior calyx because they are accustomed to inferior calyx and they can easily enter and they are confident. Generally, they don't go for supracostal puncture. What will you do if pelvic stone is there? Will you choose inferior calyx, middle calyx, or superior calyx in supine PCNL?
I'll go for middle calyx, sir, unless I see that it's not coming below the costal. Yes.
Answer is middle calyx.
Yes, sir.
I also feel middle calyx is easy in supine PCNL because it comes exactly between the rib and iliac crest. If you go more towards iliac crest for supine PCNL, it is little difficult because thigh will come in picture. If you go supracostal, slightly we feel uncomfortable, even though it is not correct because we may have to go more posterior. It is not necessary in supine PCNL, but most desired calyx in pelvic stone in supine PCNL is middle calyx. With the same principles, whichever position you puncture. For example, Sandeep sir told today, after his vast experience, that he will puncture in 20-degree C-arm shifted to his side, head end of the C-arm shifted to his side. This is like bull's eye. After that, he will go to 0-degree. If the needle is towards the spine, you are more posterior. That means backside of the patient. Withdraw the needle, tilt anteriorly, puncture again. Kidney movement and calyx movement will really help whether the urine has come or not. This is the first question. I am asking second question. If the stone is in the inferior calyx, will you puncture inferior calyx or will you go from middle to inferior?
Inferior calyx.
So answer is very, very correct even in my perspective. This is not a debate. This is not the final answers. This is our experiences.
Yes, sir.
Last 3 years, 15 years, I have done prone PCNL. Last 4 years, I am doing supine PCNL. I am sharing my experience. If the stone is in the inferior calyx, we will puncture inferior calyx only because if you go to middle calyx, turning from middle to inferior is little difficult, I feel. Turning from middle to inferior is little difficult in supine. Whereas in prone Chinese technique, most of the people go through the middle calyx to inferior, middle calyx to superior calyx. That's why Chinese prefer middle calyx. Even Dr. Khadge sir from Nepal, who is very pioneer in middle calyx minipar, he always goes through the middle calyx because it is isocentric with the pelvis. Whereas if the stone is in inferior calyx, in supine PCNL, better to go through the same calyx, as Sandeep said, and I am also accepting that. Number 3 question. If you have kept in modified lithotomy and if your needle is hitting the thigh while doing the inferior calyx, do you straighten the leg sometimes?
Yes, sir. Many times I also tell my assistant to hold the leg.
Yes. So I am 100% I'll accept that. See, these are the fixed principles in supine PCNL. A lot of people will say it is cumbersome. If you keep in lithotomy, RIRS is easy. If you keep the leg in straight, supine PCNL is easy. When you want to combine, you keep slightly in lithotomy position. So whenever you want to puncture inferior calyx, if it is quite angulated, if your thigh is coming in your way, better to keep the thigh straight like in prone. Then you will easily reach the inferior calyx, at least lateral part of the inferior calyx. So dear friends, you should be in a position to change your leg. Sometimes what Sandeep sir is saying that you will keep the leg by assistant for just short period of time where you will puncture it. These are the cumbersome aspect of supine PCNL, whereas in prone, there is no need to change the leg, no need to change the patient position. You can comfortably puncture the inferior calyx. So inferior calycial puncture, if it is quite deep, difficult in supine PCNL. Do you agree or not, Sandeep?
Yes, sir. Yes, sir.
Yes. Now, when you wanted to reach the superior calyx in supine, in prone surgery, people easily go superior calyx by going above the 12th rib. can you go easily in supine PCNL or not?
It's difficult, sir.
It's difficult. Why do you, I slightly differ.
Sir.
Most of our punctures in supine are horizontal or 10 to 15 degree tilt only. So even if you don't tilt the patient, you can see the lateral aspect of the 12th and 11th ribs. So you can reach the lateral part of the superior calyx easily. If lateral part is not present, if the calyx is very, very straight upwards, then supine PCNL is difficult. If the superior calyx is straight facing towards the head without any lateral calyx, normally it is a compound calyx. You have a facing towards the head, you have facing towards the lateral. If it is facing lateral, supine PCNL is easy. If it not at all present, just go up straight calyx towards the head, then supine PCNL is difficult. Do you agree, Sandeep?
Yes, sir. Definitely, sir.
Definitely.
I also make direct upper calyceal punctures also for superior calyceal stones.
Yes.
But as you said, sir, we have to see whether we will be really able to do it or not after giving contrast. What is the position of the calyx? And sir, one more important, sir, thing. Puncture is thing, but after dilatation, how much of space we'll get, how much of maneuverability we'll get, that also we have to forecast.
So we are openly discussing the disadvantage of supine PCNL also. It is not that which is correct. If you know both, for example, if I know prone and supine both, we can select maybe 10% only supine, but in selected cases, it is very useful, especially when you are planning RIRS, especially when you want to have access from below. Supine PCNL is very useful.
Yes.
Sandeep, in your practice, when will you say that this is done by only supine PCNL? One or two examples you give. I wanted to go only supine in this case.
Sir, I will say any inferior calyceal stone, middle calyceal and pelvic stone.
Yeah.
I will obviously first go for supine, sir.
Supine PCNL.
But staghorn cases, upper calyceal stones, still reservations will be there. But in a single stone in lower calyx or middle calyx or pelvis, I always feel supine is best.
In that case, entire society will ask that why should we learn supine? If prone can do all the job, is it really such a big task to turn the patient? See, when I was doing 15 years, I never thought that turning the patient is a big task.
As I said, sir, patient selection is important. The advantages of supine are already enumerated.
Yeah.
So it's about comfort.
You will consider those advantages only for your case.
Yes,
if I'm not wrong.
Sir, as I said, initially it was a compulsion for which I started supine. But then I liked it. I was very comfortable. I could even sit and operate. So gradually I was like, why not develop this technique? And gradually over a period of years, I've more in favor of supine, sir.
Okay. I wanted to share a piece of information here because I do RIRS more. What I realized after attending the Trichy conference in 2018, whenever there is a bifid system, if you have a small stone in the upper calyx, if you have a large stone in the lower part of the system, you can bring that small stone with RIRS down and finish rest of the thing by supine. This is what highly advantageous I feel if you have multiple small stones with a large one stone. If you have multiple stones, 1 centimeter, 1 centimeter, 1 centimeter, and one big 3 centimeter, you need not puncture all calyces, you go. That means I mean to say ECIRS wherever it is useful, wherever you wanted to put the flexible scope from below, in those cases, supine PCNL is very useful.
Yes.
But as Sandeep sir said, the staghorn calculus, I have also gut feeling that prone PCNL is easy. Because water will stay, picking out of these stones is easy, large stones, and usually pneumatic lithotripter breaking is also easy in prone. In supine, sometimes you have to be slightly angulated against the gravity. Do you agree?
Yes, sir.
Yes. So sometimes if the water outflow is not good in supine, some amount of the bloody field will be there. Do you agree?
Yes, sir.
Yes. So clearly, we both are correlating that middle calyx is better. Inferior calyx can be punctured. Superior calyx, he said that it is difficult. I say that yes, it can be done provided the lateral part of the calyx is available. Wherever the RIRS is feasible, supine PCNL is better. Staghorn calculus, the prone is better, we feel. See, literature, you can get support for this, you can get support for that. Nobody can say which is better. That's why this forum in Pure Urology is personal experience based. No conflicts of interest. He has certain experience. He made in USI newsletter writing, and I have done maybe around some hundreds of cases in supine PCNL. With that experience, we are sharing. Now, one more question. Do you think that in supine PCNL, the water has to be flushed forcibly from below? Not necessary. Or you have to raise the water from too much to have good vision? If the puncture is good, it's all not necessary.
Sir, sometimes I tell my assistant to raise the height or give a pump, but from below, I generally don't tell them to flush. It's not required. Do you
use any ureteric catheter with multiple holes? Do you have that facility?
No, sir.
I also don't have. Nadiad people uses that, but somehow I have not used. What size of ureteric catheter you use for the RGP?
5, sir.
5 French. Okay. What nephroscope you use for supine PCNL or any PCNL?
Sir, Wolf, the Dresden.
Dresden?
Dresden, yes, sir.
Dresden. And normally your tract dilatation is how much?
Sir, I do single step dilatation. I don't go for gradual dilatation.
The single step dilatation means after puncturing, you pass guide wire. Next 1 or 2 dilatations you don't do, you will do.
Sir, 1 or 2 facial dilators, that too if required. Otherwise, sir, I use that Alken cannula.
Alken rod over that single step dilatation 22 size.
No, sir. First, I use that Alken, the 2-part metal.
Metal Alken.
Metal dilator.
Okay.
Then the guide rod and then a corkscrew single step dilator, sir.
Single step dilatation with 22 French?
24, sir.
24 French?
24.
You don't have any problem?
No, sir. No, sir.
What guide wire you will pass?
I use Terum.
0.035 or 38?
35, sir.
I am slightly conservative. I will dilate up to 10 French, 12 French with serial dilatation. After that, I will go with the Alken rod. Alken rod serial dilatation is my technique. But entire world single step dilatation is doing. Maybe I'm little afraid. So I will go by step. That is totally personal. Uday Shankar has asked a question in Siam. One is X-ray tube below the table, not visible. Another is head or camera over the table, visible. X-ray, I don't know exactly what he is asking. In Siam, one is X-ray tube below the table, correct, not visible. Another is head or camera over the table, correct. I don't know whether he asked a question or he is conveying the message. In any Siam, X-ray generator is below. What you will see on the top is receiver. So generally, tilting is named on the receiver movement. Tilting towards you means receiver.
Receiver, yes.
Tilting away from you means receiver. Tilting towards the head means receiver, top part. Because that is the only one you see.
We see, yes, sir.
So don't ever confuse. Any surgeon will say only top part movement. Head end, foot end, towards the surgeon, away from the surgeon, like that. So that's a good point. If the needle tip moves along with Siam camera, it's deep to stone. Anyway, it is all interpretation. See, every person interprets in 3 positions. One is, as Sandeep sir said, towards you, away from you. This is one position. Another person's interpret towards the head end, away from the head end. It is all up to you. You remember what happens to the needle when you tilt in the opposite direction. In any position, needle should be in the calyx. Whatever you do, 30 degrees, 0 degree, head end, tilt end, foot end, any angle you tilt, If the needle is in the calyx, you are 99% you are in the calyx. But you have to remember mnemonic, you have to remember the logistics. What today topic is, Sandeep sir said, if your CM top end is 20 degree towards you, then if you go to 0 degree, if the needle goes towards the spine, it is posterior. If you like it, you remember, that is all forever. If you want to make your own, fine, no problem. Nobody says that you remember this, you remember that. Ultimately, needle position movement with movement of the CM, you have to remember. Now, my 7th question. If you have a large pelvic stone and middle calyceal stone, normally, when you pass the guide wire, would you like in supine PCNL the guide wire to be parked in the ureter, or anywhere it is okay, or if it coils in the calyx also, it's okay?
So obviously, the first preference will be the guide wire, if possible, should enter the ureter.
Ureter. So everybody says that you manipulate 1 or 2 times.
Yes.
If the guide wire goes into ureter, surgeon will be very happy because chances of guide wire falling out is less. Dilatation, you will be confident. And ultimately, you reach the stone guaranteed because you are in the ureter.
Yes,
so
sir.
you like to have the this thing. If the contrast is not going into the pelvic calyceal system properly,
During RGP, sir.
RGP, if the stone in the supine PCNL, you have a stone in the pelvis impacted, contrast is not going, you don't have an ultrasound. Because ultrasound is not available with everyone in India. The moment you say ultrasound guided puncture, people don't like in India because they are not used to it. Their training is not used to it. There are a lot of rules, P&AT rules. There is no trajectory. The probe is old, ultrasound is old, so many problems. Do you have any trick for blind puncture, or what will you do? It's a tricky question, don't mind.
No, sir. So first of all, I have not faced such a situation till now.
Yeah.
So I really don't know how to answer this.
My feeling is that in supine PCNL, I asked. In prone PCNL, don't mind, Sandeep.
Sir, no, sir.
Lot of audience are there. They should also get benefited. In prone, normally there is saying that below the 12th rib, if you go 45 degrees angle in a dilated system, if you are lucky, you can get with 1 or 2 times water. Otherwise, you should not do anything. But in supine PCNL, what I observed is, I take a flexible scope, I go to the stone, I little manipulate and inject. One of the calyx will definitely get opacified when compared to ureteric catheter. When ureteric catheter is not going beyond the pelvic-ureteric junction, if I go with flexible scope, I can inject at least one of the calyx faintly visible, then I can finish the procedure. Otherwise, worldwide, ultrasound is the only answer. Do you agree?
Yes, sir.
I am sharing my only trick.
Yes, true,
to inject, because ureteric catheter, saline will come back, the contrast will come back and it cannot distend, whereas flexible ureteroscopy, you can bend a little bit towards the lower calyx, inject, some amount of contrast will go into the calyx, and then you can get rough idea where is the calyx and then proceed.
Okay. Sir, here, instead of doing the, I'm just asking you, sir.
Yeah.
Can you just blast the stone a bit so that...
Yes, if it is patala stone, if it is not very big, make a small one area space, and
so
then
that the contrast can go.
Yeah, I manipulate from below a lot in supine PCNL, a lot.
Okay.
Because 2 screens, 2 surgeons are available in my own hospital. 2-3 people are there. They can manipulate. Every time it may not be possible, but sometimes when you are really requiring, you can't puncture the pelvic stone. You can't. Nobody will puncture the pelvic stone directly. Somehow you have to delineate the system. Yes. But most often the system will be dilated. If you puncture, some amount of water will come, you inject contrast. After that, you choose whatever the best calyx you wanted to go. That is possible. But blind puncture is not recommended. Ultrasound is better.
Yes.
Now coming to the 8th question. After the, do you do RIRS regularly?
Yes, sir.
Yes. After the supine PCNL, if you have any small stone, will you take up after 2-3 days or will you take up after 1 month? With nephrostomy in situ, will you like to take in the same admission or after 1 month removing the nephrostomy? I hope you are understanding the question.
Yes, sir. Now first thing I would like to say, sir, I rarely put nephrostomy, sir.
Oh, you rarely put.
Most of my PCNLs are tubeless or total tubeless. In fact, sir, nowadays what I'm doing is, I don't know it's right or wrong. In many clean cut cases, I don't even put the UCAT. Or if I put the UCAT, I remove it within 24 hours.
That means you are not putting the tube, you are not putting the stent.
In selected cases, not even stent.
When
in selected
your surgery
cases.
goes straight forward without any problem, you
Correct,
went
sir.
inside, no bleeding, 2-3 pieces you made,
Correct,
you
sir.
taken out, absolutely no residual stones.
Correct, sir.
You don't put stent
no bleeding
also.
Yes, sir. Or a pickup stone. I went in, pickup stone, or as you said, sir, minimal fragmentation. I'm absolutely sure there is no residual fragment, no bleeding. I just either don't put a UCAT also, or I put a UCAT, remove it within 24 hours.
Okay. Generally, it is done by all the people nowadays. Mini perc is less than 20 French, nephroscope is the standard. If the puncture is very good, there is no bleeding, there is no need to keep nephrostomy. Lot of the seniors like SK Pal sir, Deshpande sir, Patnaik sir says, Sabnis sir says, putting the stent is optional. Lot of the people, urologists will put the stent. But if you put ureteric catheter for 1 day, nothing will happen. But as far as me concerned, generally I put 1 day nephrostomy. Generally I put stent and remove after 2 weeks.
Okay.
This is my old tradition. Sometimes if it is pickup stone, I don't put nephrostomy, but stent at least I will put in all cases. There is no debate, there is no conflict of interest, there is no discussion on this. It's all you will decide. It's all you, ultimately surgeon comfort, patient comfort, if you can give, that is fair, very good enough. And most of the world is moving towards tubeless PCNL. Most of the world is moving towards tubeless PCNL. I agree for that. One more question from Uday Shankar has written a lot of things. Chatterjee, he is also from probably from Kolkata. Would you like to get the depth of the stone or calyx with MCCT KUB? See, it's important question. He asks that most of the stone cases, we are getting CT scan. In CT scan, we see the stone, we see the Hounsfield units, we see the size, but we don't see which calyx it is seriously. We don't see what is the skin to stone depth. I don't see. I will do RGP. RGP will decide me the roadmap and that will tell. Is there any way a CT scan will help in stone? Means generally number of stones, for example, multiple stones are there. We will count in CT 1, 2, 3 like that. So we have to remove 4. But calyx anterior, posterior in CT identifying is very difficult. You can identify, but interpreting for that puncture is difficult in my opinion. What
yes,
do you
sir. Yes, sir. Definitely, sir. I don't rely on CT for my puncture planning and everything.
Yes.
In fact, I feel, sir, IVP will make me understand the planning better than a CT.
That's why if you have doubt, if you are in periphery, if you want to know before only, IVP still holds good. Malrotation of the kidney also can be detected in IVP.
Yes.
In CT, malrotation can be easily detected, but how much malrotation, how much RGP picture change will come, what way you will change the puncture in CT is very difficult. Whereas in IVP, before going to the theater, you can imagine lateral, medial, where is the stone, for horseshoe kidney, how much deep anteriorly rotated, you can definitely assess. But in CT reconstructed also, calyces will not be seen that big except if they are too much dilated. Calyceal anatomy without contrast assessment for the puncture probably is difficult. I feel, but he is asking for the depth. Yes, obese patients you say 10 centimeters, but when you start puncturing, you may be in any angle, it may be 12 centimeter, it may be 10 centimeter, it may be 5 centimeter. We don't know.
Yes.
In CT, exact one axial cut it will get. But when you do real CT, real puncture, you will change angles so that your needle may go more than your original depth. What do you say?
Yes, sir.
Yeah, that is what
RGP is the thing which will.
Without RGP, if somebody is doing PCNL, it is not acceptable. So never ever lose the ureteric catheter position. In fact, I wanted to ask you, where will you keep the ureteric catheter? Upper calyx, pelvis, or little below the pelvis?
Sir, just below the pelvis.
Yeah, I always keep in the upper calyx. After that, I will withdraw because
No, sir, yes, sir. Initially, as much up as possible.
Yeah, as much as that. That's what I am asking. Initially, don't perforate, but as much as possible, upper calyx you keep. Because if you keep in below PUJ from beginning, it will come to mid-ureter.
Yes, sir.
If the contrast doesn't go, oh my God, in prone PCNL, it is hell.
Hell, sir.
In supine PCNL, at least you can retry. In prone PCNL, it is hell. If the contrast is not coming into the kidney, sometimes you have to turn back, reposition, and then turn back.
Yes.
Oh, it's big nuisance. It's big nuisance. And my ninth question, a lot of the people are doing supine PCNL, prone PCNL under spinal anesthesia. Very cost effective. 4,000-5,000 rupees can be saved. In the present era of difficult surgical practice, because of so much peripheral practice, so much competition, spinal doing PCNL is acceptable, but I am not able to do because I am adjusted to the comfort. My kidney will be fixed with an anesthesia. I'll puncture, luxury. Then, but when I do under spinal, telling patient that you stop. If you say you take a small breath, you will take deep breath. I'm not used to spinal punctures.
I'm also not comfortable.
You are also not comfortable.
For the same reason.
Even RIRS also, I am not comfortable in spinal. I
but
can't.
Sir, yes, people are doing in supine.
I can't do a fine powder with RIRS.
Yes, sir.
Sometimes the laser hits the mucosa and we are afraid. So I don't know the public audience, but a lot of people are doing in spinal. They say that they never have problem. They are more, especially youngsters, are able to do with patients, and they are able to do. This is my 8th question. Coming to the 9th question, do you do the nephrostogram at the end of the last 2 questions only? Don't worry.
Yes, sir.
I hope we are finishing. Do you do nephrostogram at the end of the procedure in supine PCNL always or not?
As I said, sir, I do tubeless.
So no question of.
I don't do.
You don't inject any contrast.
No, sir.
Okay. I wanted to give a small suggestion for the audience. If you feel that you are more anterior in your calyx, while coming out with nephrostomy, while coming out with nephroscope, keep injecting and contrast. 100% you are sure that contrast has not gone into the column. If you have doubt on table that something is fishy, if you are keeping nephrostomy, do nephrostogram. It will clearly delineate perinephrostogram contrast into the column. If you are not putting nephrostomy, while coming out, slowly inject contrast through the nephroscope and come out. So that if it is a single line, very good. If it is deviating and colonic, it will 100% pick up. 100% it will pick up. So on table, you can say that I have not done any colonic injury. This is my very important tip from my heart. I am telling that when in doubt, colon or pleura, inject contrast at the periphery of your calyx to the skin. Then you will clearly know where the contrast is going. If it is pleura, it will take a nice concavity. If it is colon, at least 4 to 6 oscillations will be seen. This is my favorite point. So I do nephrostogram if any difficulty, if any perforation, or if anything. Otherwise, I also don't do. If I am below the posterior axillary, I won't do it. Now, last question. What do you think in future? Lot of shift is happening from prone to supine. If the RIRS picks up, if flexible scopes come very low cost, do you think that supine PCNL, the training as well as the incidence of supine PCNL by the juniors will increase in the future? What is your opinion?
Sir, it's already increased. When I did in 2016, I was mocked about. I was told what you are doing. So I was the only person who did in East India, if I may say so, who are doing regularly. And now, if you compare from 2016 to 2023, you yourself will see, sir, you yourself have picked it, sir, after you are a pioneer and you are such a, but you have also come to spine. I'm not saying prone will go. Prone will have its place. Supine has created its place.
Yeah.
Supine has created a place.
Yeah. After the RIRS, after the ECIRS, after the technique evolved, after the juniors are seeing, after even I might have promoted also, some people say that you have promoted. It's not the promotion, it's not a company. Supine PCNL is not a company. What we are saying is that I tried, I enjoyed, I continued.
Correct.
Now I am taking advantage of the ECIRS. I tried, as he said, same. I felt it's okay. After that, I felt comfortable. After that, I'm used to it. Now I don't feel that I want to turn the patient. And sometimes I feel very advantageous of whenever a scope is put inside. We are not propagating. Nobody should say, I'm an RIRS surgeon, I'm a supine PCNL surgeon, I'm a prone PCNL. That's not correct. Always I mention, you should be able to do all the surgery, including laparoscopic ureterolithotomy. You should be able to do so that the patient gets benefit of minimally invasive surgery. Please do not consider sometimes, actually speaking, we have not done much topics on prone PCNL. We are coming next week. Our anniversary of pure urology is happening on 24th.
Okay, sir.
So Dr. Sabnis sir is speaking on prone PCNL, how to avoid complications and safely do it. It will be very, very useful program. So we are focusing only on prone PCNL on that day. So he will tell the tips how not to do any damage to the patient in whatever circumstances, whether angio available or not. Please do not miss this topic on 25th, which is our pure March 25th. 2 years back during Corona time, we started nearly 250 presentations we have done, probably your 249th presentation. And I'm very happy that multiple topics are, so don't, what I mean to say, don't misunderstand that prone PCNL is not good. It is excellent for staghorn calculus, for any stone, but supine PCNL also has certain advantages. Please understand that. Thank you very much, Dr. Sandeep, for sharing your valuable time. Let's hope, what is your other area of interest?
Sir, laparoscopy, sir.
So let's in future